co-sponsors this meeting with the BMJ. And I'm delighted to have you all join us, and for our 4 presenters to join us today as well. We've invited 4 people representing 4 different national strategies. Each of these organizations and each of these people are going to share their quality strategy. So they're all using quality as a strategy to manage their systems during this time of economic constraints and reform. I will introduce them. So the first speaker is Chien Lee, Beth Lilja, Jonathan Gray on the end, and Jill Vickerman. You mix me up. Chien is from Singapore, Beth is from Denmark, Jill is from Scotland, and Jonathan is from New Zealand. I'll have each of them will speak for about 7 or 10 minutes. We're going to time them. And they'll share with you their strategies, their quality strategies, and some of the challenges that they face within their countries. And then we're going to open it up for some questions. And then we'll wrap it up with each of them sharing some tips for all of you. Does that sound okay? Okay, so Chien Lee, if you would begin.
Sharing tips was great.
Okay. Good morning, everyone, and thank you for this opportunity to share this forum. Although Penny says it's 7 to 10 minutes, I think one of the problems that I have is I don't listen very well. So it may extend a bit longer. So, but you will work out as we go along the way. So, firstly, greetings from Singapore. If you are wondering where we are the small red dot at the bottom. So, we are a very small island, land area less than 700, around 700 kilometers square, a total population of 5 million, and a per capita GDP of 50,000 USD. Health outcomes-wise, we have done quite well in terms of our life expectancies, infant mortality, and at a much lower cost, spending around 4% of our GDP on a total healthcare expenditure. But we have a few big challenges facing us. One is our growing population. Secondly is our aging population. As you can see, we are no more a pyramid. We are like looks more like an aircraft carrier. And our elderly patients currently account for 9% of our population, but they take up 40% of our total inpatient days. And they will stay longer, and we anticipate that our number of elderly will grow from the current 9% to 13% in 2030. Sorry, that's 2030 instead of 13. So it's a quite significant increase. And while our premature mortality rates have decreased for key diseases such as cancer, ischemic heart disease, and stroke, what has happened is that these previous killers have now become chronic diseases. And looking at in terms of our burden of disease, more than 50% of our total disability adjusted life years have been due to living with ill health or living with disability. So we have set out on the triple aim, the Singapore version, which is our mission is to enable our population to live long, live well, and with peace of mind. And the triple aim, our version is better health, focusing on health rather than healthcare, better care, focusing from a longitudinal integrated system instead of the current episodic care, as well as better value, moving from just talking about cost, but looking at cost effectiveness. And why is quality important? I think quality is important because first, as goes by this definition, it's about doing the right things. And we believe that if we do the right things, it will, in the longer term, make the system more sustainable. So quality is critical for a sustainable health system by optimizing outcomes, not only reducing mortality, but also morbidity. And at the same time, ensuring affordability and sustainability. By doing the right thing to the right person at the right time, as well as at the right place, it reduces waste in terms of money, space, time, and talent, and also eliminate unnecessary process variations and things that don't add value. So the approach that we have taken is, I think, no stranger to many of us, is looking at both the strategic, the cultural, the technical, as well as the structural requirements, as well as looking at it from the various systemic levels, the patient, the microsystems, the organization, as well as the environmental level. And for our better health, our aim is to move from thinking about activities to thinking about ecosystem. So, and we see that healthcare actually is just a small part of this overall ecosystem if we want our population to live a healthy life, and it needs capacity building and data to support such activities. Same thing for our screening programs. It is not enough to screen someone. We must increase the channels for them to be screened, and there needs to be a supportive environment. And this supportive environment is not just for them to be followed up by their doctors, but also to be followed up at home so that their family knows how to cook for them, how to manage them, and community interventions, getting peers to encourage them to continue to live a healthy lifestyle, and sorting out all the financing as well as the quality issues to ensure that only the necessary screening tests are ordered for the patients. And what we are doing is, in terms of creating an ecosystem, is to create social movements, turning people from bystanders to activists. And one of the key objectives that we have tried to do is to create an army of what we call 10,000 health ambassadors. These are lay people who are in a way screened and brought forward to do this. And from a calculation, if each health ambassador reaches out only to 3 people, over 4 cycles, we will have reached 1 million people, which is around 1/5 of our population. And for better care, we recognize that a hospital-centric model is not sustainable, and therefore we need to integrate care into the most appropriate setting. And as such, we need to take a life cycle approach. For a patient, what do they want? If I do not have a stroke yet, obviously I don't want to get a stroke. If I have a stroke, I want to survive the stroke. But if I survive the stroke, what do I want next? Which is to be able to recover and integrate back into society. So for the quality perspective, we are trying to see care from a life cycle approach and transforming care from a silo to a systems approach, moving from an institution to a population-based, and therefore we have sought to organize our services around the patient and created 6 regional systems, each with the honeycomb, as you can see, around the island, so that they can better manage the population, rather than looking at what services we deliver, looking at what services do the patients require. And in terms of measuring outcome, not just measuring outcome on an episodic, on a time limited, but measuring outcomes from the recovery and from the patient's perspective. Okay. And we have developed what we call our integrated performance measurement framework, which is a national scorecard, which can be cascaded down into a sector scorecard, such as a hospital scorecard, as well as a provider or a specialty level scorecard. So this information flows both up and down, and it enables us to think through on a cause and effect perspective. If you say that something is being done very well at the specialty or the provider level, it should over time show itself up at the national level. If it doesn't, could there be something wrong in our theory? Could it be because the enrollment rate was too low, the program was good, but it was not scalable? Or could there be something else missing, and how can we better improve it? So our national integrated performance measurement framework is aiming to do this so that we can follow up the patients across the life cycle. And we are trying to invest for the greatest impact using health technology assessment to assess alternatives along the care path, looking at not just mortality, but also morbidity, functional status, complication rates, and all this will be added and put together and link up into what we call integrated care pathways. We are in the process of developing 5 integrated care paths. The first one, which is a COPD, will be launched next week. And each of the integrated care path has 2 components. One is a clinical team, a national team which works out the care elements at the national level. These are the evidence-based elements that I've shown you earlier, in which our health technology assessment people have come up with. And for this is for compliance, because it's been evidence-based to be cost-effective, to proven to reduce mortality and morbidity, and is prioritized as a key item. Then it should not vary regardless of where you stay or which provider you seek. But at the same time, there's a contextualization process. Who delivers it, how it is delivered, would depend on the local circumstances. Therefore, at the implementation team, there would be the doctors, there will be the allied health, the nurses, there will be AIC, is our Agency for Integrated Care, which is the agency we set up to integrate care across the country, as well as the Ministry of Health representative inside to work out the care elements. And we need to enable some key sectors, because as we were rolling this out, we recognized that some sectors were relatively weak. Our primary care sector is something that we need to strengthen, because currently 80% of our care is provided by our GPs who work on the fee-for-service system. They are not funded by us, and they are virtually independent providers. So how do we bring them into the system? So we realized that we need to take a multi-pronged approach, enabling the financing schemes that patients can have portable subsidies, so that when patients go there, they do not pay any different from what they pay if they go to a government polyclinic. Creating infrastructures. If the GP needs team-based care, if the GP needs support services, how do we provide them? And at the same time, allowing closer collaboration through IT systems, and enabled by a dynamic information management system that tracks the patient. And this is what we are developing, a national electronic health records, which at the same time, a subset of it can go into a personal health records, which is also linked to other things, because we recognize that patients don't go to a site just to get their medical info. They go to a site because they want to interact, so we're trying to see how can we leverage on social media to get patients to be more involved in their care. But ultimately, it is about the person, right? We can provide whatever we want, but if the patient or the person is not compliant, doesn't see the need for it, as Maureen says, it is not what matters. It's not what is the matter, but what matters to the patient. And this is something that I learned from Mayo Clinic, where they actually ask the patient, do you want to take the statin? Rather than giving the patient and be happy that every patient has been given statin and we have a tick, but did the patient actually take the statin? So I think this is something that we are trying to do, and we are looking at quality as an underlying theme in terms of our healthcare reforms. Thank you very much. And
you next. Thanks, Beth. And thank you, Dr. Chien.
Good morning, and thank you for inviting me. I'll talk about the quality and safety agenda in the Danish healthcare system. I come from the Danish Society for Patient Safety, and that's a non-governmental institution that has become the common framework for the stakeholders in healthcare in Denmark for the work on patient safety. I thought for the talk today it would be necessary to give an overview of some of the basic principles for the Danish healthcare system. We are a public healthcare system with finance through taxes, very small private sector. We have a free and equal access for all citizens. We have a freedom of choice within certain limits. You have to choose your GP within this area. But basically for hospital care, especially for planned admissions, you can choose what hospitals to go to, and so on and so forth. Finance through general taxes, as I said, and we have a decentralized organization. The gatekeeper to get access to healthcare on a higher level is the family doctor. So there are three political and administrative levels. There are the municipalities. We have 98 of those. We are 5 million people, like same size as Scotland, same size as Singapore is soon going to be, and I don't know how many we are in New Zealand anyway. But 90 municipalities, and they're responsible for the part of primary care, like nursing homes, home care, and so on, so forth. Then we have 5 regions that are responsible for hospitals, for specialized care, and for general practitioners. And finally, there's the government or the parliament, the parliament that takes care of legislation. The municipalities and the government can write out taxes. The regions can't. They have to negotiate with the government about how much they can spend on healthcare each year. So if you look at the expenditures within the regions, most of the budget, of course, are used at hospitals. And you can see here the slices of the cake that are used for general practitioners, specialists, and dentists, and so on, and how much that are used for medications and reimbursements on medications. This is the amount of the gross national product that I spend in Denmark on healthcare. It's growing, and it's about, I think it's about 11% now. It says 10 here, but I think it's 11. And you can see how it equivalents to the other OECD countries. We are spending a little more, but not as much as the US. So how are healthcare developing in Denmark? Well, we have a reduction in the number of hospitals and the number of beds, and that reduction has been especially taking place over the last 3-4 years, because there was a restructuring of the public sector. We went from 11 counties to 5 regions, and that made it a lot easier to reduce the number of hospitals. There's been a lot of centralization and specialization, fewer hospitals with emergency departments, lots of focus on pre-hospital emergency care, focus on intermediate care, and then it has been decided to renovate the hospitals and to build new hospitals. We have quite a number of hospitals that are before the Second World War, actually, and these plans and some of the regions have started to build now. So that's taking place right now. And then on the level of the primary care, when it comes to general practitioners, there's a tendency that they collaborate in larger clinics, which is something that are seen as a great advantage. So the quality agenda, well, quality is seen as part of the solution to the same challenges that we all have. We look as an aircraft carrier as well, but we are thicker, higher up than Singapore. We all have to deliver more for less. And that means we need to focus a lot more on the patient. I think it was put very nicely by Maureen yesterday, what matters to you. We have to do the right thing the first time. We have about 1 out of 10 patients that are harmed during their stay in hospitals. We have lots of waste of patients' time by the way we are organized. So we have to do the right thing the first time. We have to have more coherence in the action, meaning that we both have to comply much more with the guidelines that we have, but we also have to to close some of the gaps from the silos, both from the primary care sector to the secondary care, but also the silos within, within smaller units like a hospital that are silent. So having a coherence in the action is part of the quality agenda. Over the last, I think 2 years ago, it was a general accepted that good quality means extra resources. But I think over this last 2 years, it has been accepted that good quality is not an additional expenditure, but bad quality is. And that's a change. But right now, the quality and safety agenda looks a lot like this to most people. We have an enormous amount of quality and safety programs on the national level. We have an accreditation model, we have a national indicator program, we have cancer pathways, we have a patient safety reporting system, we have the list is long on each of these levels. On the regional level, each region has their own quality and safety strategy in addition to the national strategy that goes on different ways of reduction of harm and mortality, safe surgery, regional clinical guidelines, so on and so forth. A long list of that. So has the individual hospitals. They have pressure ulcer bundles. They have a lot of different programs as well. And so has the individual departments. And I think that both leaders on the national, the regional, and the hospital level sees themselves as victims of all the other quality and safety programs that are not necessarily aligned. Each and every one of them makes a lot of sense, but together it might not mean that it is sensible by the way they are launched and are run during a daily basis. It's not easy to solve this problem. Most leaders feel that they have to balance also, 1 month there's a special focus on this and we have to do something about that. The next month it's the other plate that they have to keep in the air. But things are moving forward. And these are some of the results that has been achieved over the last couple of years. There's, due to the cancer pathways, there's a reduction in waiting times for cancer, which was a big problem. And it's still a problem for some diagnoses, but for others, there is a reduction in the waiting times. Waiting times in general has gone enormously down. You can basically get a hip replacement or a knee replacement from day to day now. We have a huge increase in productivity. And our average length of stay is now down to 4 days, which is a huge decrease, and we are the lowest one among the OECD countries. We're starting to build capacity and capability to make changes. And we have a consensus among the stakeholders in healthcare that we need to accelerate the way we are changing faster than before. And the consensus thinking that the healthcare decisions are made on in Denmark is really very valuable when it comes to an initiative that you launch, because then you have you have the backing to it, you have the fundament, you can go ahead with it, and that's a huge advantage. But we also have barriers, and one of the barriers is, from my point of view, an obsession by measuring for benchmarking. Every time a new measurement comes up, a new indicator, it's for benchmarking. And everyone is discussing the tool, the measurement tool, and not how to improve. So I think that's a huge barrier, the obsession with measuring for benchmarking and not for improvement. We're thinking and acting in silos. We do not analyze the problems so that we can limit it to this is the problem. We're going to have an action plan to solve it like this. We have a culture that in many ways accepts the mediocre. Danes do not say, we want to be the best in the world like they do in Scotland. That would be a very un-Danish thing to say. We accept. But you have overcome the challenge. We'd like to learn from that. A lot of our benchmarking data, you get the feedback that you are above average, you are average, or you're under average. And when you get that you are on average and you have all these other things to deal with, you kind of accept, pretty good, let's go on, let's focus on something else. In all the talks, patients and relatives are seen as a resource, but we don't really act that way. We do not have the prioritization of aims. Our consensus thinking that in one way is an asset, is in other ways also something that delay progress. We know that we need to deliver more for less, but we do not really act yet as if safety and quality are part of the solution. But we have a new situation now. We have a new government. They took office in the fall, and a new government always needs a new politics. So one thing that is pointing forward is that there's a committee they set down a committee that are going to work now for, I don't know how many months, but it's a rather fast thing to look at the incentives to healthcare, including quality and safety, to see if we can change the incentives or incitements in order to improve quality and safety. And quality and safety, the regions and the government has now agreed that part of the annual negotiations that are usually about finances and about productivity will this year, and they're going to take place in June, also have safety and quality as part of them. And that's a great advantage. One of the things that has driven this change has been a project that we are running with IHI and with great help from our friends in Scotland, with great inspiration from some of Jonathan's work in Wales. Is a safer hospital project that we ran that had the overall aim of reduction of mortality of 15%, reduction of harm 30%, and so on, and with a number of other aims as well. And many of the hospitals are very successful in achieving some of the lower aims right now, and that has created some optimism that it is actually possible to reach some of these to reach results, and it's seen as a little part of the solution out of the many, many quality and safety agendas that are not aligned, that maybe the way forward would be something like this. And this is my last slide here, that right now, this was from the one of the main papers yesterday, it is being very possibly highlighted this initiative in the press, and that of course also creates some optimism that this might be the way forward and put some pressure on the healthcare system as well, that maybe this is the way to go. Well, thank you.
Thanks, Beth. Thank you. Jill, do you want to? Okay, so now we're going to hear from Scotland, and Jill Vickerman.
Okay, I've actually taken a slightly different approach to telling you about the challenges of establishing quality as our sort of imperative, if you like, for developing policy and driving forward our strategy for healthcare in Scotland. The colleagues from Singapore and Denmark who have described some of the detail of their quality strategies, I think there's a huge amount of similarity actually. Scotland is a country also of around 5 million people, and we have over the course of the last 2 or 3 years agreed that the pursuit of quality is the way that we are going to tackle the challenges that have been so well described in the previous 2 presentations around about the sort of resource constraints, the growing population, the increasing availability of expensive technologies and medicines, the increasing demand and expectation from patients and public, the sort of longer living and multiple morbidities that we see in the ageing population. All of that had meant to us that we really needed to draw a line and take stock of what our sort of future direction of travel was going to be. And so I wanted to talk to you actually more about how we did that rather than the details of what the result of that was. So I hope that provides us a slightly different perspective on the discussion, and I'd be really quite keen to sort of get into the conversation afterwards with its other colleagues about how much of that actually sort of resonates with them as well. I have a role in the Scottish Government. The Scottish Government is a devolved government within the United Kingdom, so a slightly different situation, I guess, from some of my other colleagues. However, in that devolved government, we have full responsibility for delivering the healthcare services. So we actually almost operate in a kind of independent way within the UK. And those of you who are familiar with the healthcare systems within the UK will know that there is quite a significant change taking place in England, and that there's been a range of discussions and reflections on the implications of that. We're in a very different situation in Scotland, and in some senses those of us who are involved in either having responsibility at the strategic and policy level or involved in the delivery of healthcare services are actually quite pleased that we're able to sit on the sidelines to a certain extent and watch the really difficult, challenging conversations and things that are happening down south. Our approach is very much more an integrated and a collaborative approach. We have 14 territorial health boards, as we call them, 14 health boards which cover the whole area of Scotland, and these 14 health boards are quite different in size, from about 30,000 of a population in the island of Shetland, which has its own health board, down to the sort of greater Glasgow and Clyde area, which is a health board with approximately 1.5 to 2 million people in it. So massive difference, huge sort of variation in the challenges and the environments that these health boards are operating in. And we are able to, on a monthly basis, meet with the chief executives of each of these 14 health boards and the chief executives of the 8 what we call national health boards, which provide support across the whole of Scotland. So that's things like the ambulance service and NHS 24 and the health improvement service. And we all get together and we all discuss what the big issues are that are facing Scotland. And it was through that discussion that we agreed a couple of years ago that we needed to make a step change in the way that we developed policy for Scotland, and that the marginal changes that we had all been working towards over the sort of previous 10 years were no longer going to work for us. So what we've done is we've established a commitment to quality. We've all agreed and all committed to pursuing quality improvement as our number one ambition. We have therefore achieved a situation where each of the chief executives of each of the boards is setting out in their strategic plans for the future how they are going to pursue quality. And in the next slide or so I'm going to say a little bit more about the importance of the fact that we've agreed what we mean by high quality healthcare. But as a sort of stage on from that, if you like, we then had a conversation with the politicians, and we knew we had to get them on board, not just the politicians that were in power at the time, but right across all the parties, so that within the Scottish Parliament everybody is agreed on what it is we're trying to achieve for our healthcare services. And to support that, we came up with what we've described as a 2020 vision, and it's pretty simple. It's that everybody's able to live longer, healthier lives at home or in a homely setting. Now, a lot of the things that I saw that Singapore and Denmark were doing were very much in support of this same vision. We thought it was really important to set that vision out, to agree exactly what the words of it were, and to have that at the front of our minds in all the conversations that we're having with the health service, but also with our other partners in delivering this vision: education, the local authorities, the police force, the charities and the third sector, the private sector and academics. If we all across Scotland are agreed that this is actually our priority and this is what we're trying to achieve for the people of Scotland, then it allows us to have a lot more productive and accelerated improvement, I think. So while at some level this may seem a pretty sort of simple step, it actually was very hard. One, getting everybody to sort of buy into it and agree as a way forward has been a fundamental part of the journey for us in establishing our sort of strategic position. And we're very clear that the development of our quality strategy is the sort of underpinning architecture, if you like, that helps us achieve that vision, and that's been very clearly set out and agreed as well. We worked with people right across the whole of Scotland, with the staff who deliver the services, with the charities, with the public and patients for about 18 months to listen to them about what it was they wanted from their healthcare service, and we produced this document called the Healthcare Quality Strategy. It's set out in a little bit more detail than that high-level 2020 vision what it was we meant by high-quality healthcare. We have what we describe as 3 ambitions, which are person-centred, safe and effective. And underpinning them, we did a bit of work across Scotland, again getting everybody to share the ownership of the definition of quality, to sort of pin down exactly what were the priority areas that we all needed to work together on and do improvement work on in order to achieve that vision that I've described. And this is what came out of these conversations. Again, fairly simple, fairly short statements of the outcomes that we're trying to improve, that people have the best start in life and able to achieve longer, healthier lives, that they're able to live well at home or the community, that they have a positive experience of healthcare, that all staff feel supported and engaged in this agenda, that healthcare is safe for every person at every time, and The sixth one was a really important one, and again quite a difficult one to get agreement on, that the best possible use is made of the available resources. This is recognising that I think the conversations we've been having about value, and that for the population of Scotland who ultimately own through their tax paying the health service, we need to assure them and show to them that they're getting the best deal that they possibly can for this investment, and that they need to be part of the solution to that problem. So these 6 outcomes are really important to us. They actually sort of set the tone of a number of discussions that we have about workforce development, about building capacity, about building networks across Scotland, supporting people to be part of the solution, the approach that we take to pursuing our quality ambitions. Again, those of you who have been involved in establishing visions, aims, outcomes for a whole country in such a way that they won't be undermined, that people feel a shared ownership of them, that you've used a language that is meaningful to everybody, that the other partners who are involved in having to help you deliver these outcomes also feel some ownership of them as well. It's a big job, and it takes quite a bit of time, and I think interesting to share how we do that and how we maintain it going forward, because it does regularly come under fire as other issues come onto the politicians' agendas. As another thing just to quickly reflect on, and again a sort of high-level strategic conversation that we've been having in Scotland over the course of the last couple of years, is this tension between having to achieve efficiency savings and make the books balance versus the commitment that we've made to prioritise improving quality. And I think the point has already been well made this morning that in the past that often the argument has been you need more money if you're going to improve quality, and we've really shifted that discussion, and we've positioned the pursuit of efficiency savings, if you like, underneath our commitment to driving quality, and increasingly recognise that it is through identifying the quality improvement opportunities of reducing harm and variation that we will actually have a sort of knock-on impact on reducing cost, and therefore we have sort of effectively underpinned our quality strategy with a commitment to doing the things which not only improve quality but simultaneously have an impact on reducing the cost, and therefore increasing the sustainability of our healthcare system into the future. So we produced this diagram which we found quite helpful to support the conversations which often used to take place in different rooms with different people about how to improve quality and how to make the financial books balance. And this sort of balancing scale was quite, I think, quite a useful image to have, where we're saying what we want to do is achieve the middle point here, where we select the new policies, the improvement activities, the actions that are being taken locally and nationally, which both improve quality and reduce cost at the same time. But we've recognised that there are some things that we will do which have an impact on reducing cost, which are perhaps quality neutral, if you like. They don't compromise quality, and we've accepted that there will be situations that sometimes we need to do things like that, but it's really important to recognise it, to have applied that challenge to these cost reducing measures, and make sure and hold people to account for the fact that they're not impacting negatively on our quality ambitions. So this has been, as I say, quite a helpful aid to these conversations, and we really have shifted the understanding in Scotland. Our Director of Finance now stands up at the regular meetings with the chief executives of the health boards to give them the sort of update on how the finances of the health boards are going, and he always introduces it in terms of this is about how we are using money to best effect to pursue our quality strategy ambitions, and that just little things like that repeatedly every time have really reinforced what our commitment to quality in Scotland. So this was my last slide, and it was really to set out for you, to share a bit with you what I feel are the big challenges for us at the moment in maintaining this commitment that we've achieved across the NHS, led within government, shared with other partners outside of the health service, and outside of government, when we continually get challenged with the difficult political environment. So, I mean, I think I've probably said quite a lot already about the difficult and sometimes painful but very rewarding journey we've been on to get that shared language. But to hang on to it, to hold the ring on it and not let anybody undermine it or try and change it or try and represent it as something new is something which is a really tough task. And I'm very interested in colleagues' reflections or experiences in trying to do that. We need to keep saying the same thing in the same language every time. Sometimes I feel like a bit of a broken record, but I do get told that it's only when you're completely fed up of saying this yourself that some people are actually starting to hear it. And people do need to continue to hear the same message. They need to be assured that we're not changing the goalposts, that our priorities remain the same, that the context that they're operating in remains the same. There's a real challenge for us in Scotland, having established this sort of high-level commitment to a single language and focus on quality, to have that drill right down into every single day-to-day action that's taking place across the country, not just in the health service. Because if we are sending that message out at the strategic level, and then people are seeing in the day-to-day interactions that they have with their senior managers or with their colleagues that there appears to be actually quite a different culture, then that really undermines what we're trying to achieve. So one of our big challenges just now is how do we consistently and regularly get that message and keep it going right throughout the organisation. Also, another challenge in maintaining that single focus is when we've got other big policy agendas coming onto the scene, like for us, similar to Singapore, integrating health and social care. That has become one of our political priorities. We need to quickly position that as part of the way that we're achieving quality. We can't allow that to distract us from the commitment we've made. We can't allow it to look as if it's another priority alongside what we said we want to do in terms of achieving high quality healthcare. So it's a job then very quickly at a strategic and policy level of positioning that commitment as part of the way that we pursue our quality ambitions. And the final point I've made, and this is almost a very personal reflection, is that things happen on a day-to-day basis that really try and challenge you around about the commitment that there really is, particularly at a political level, to quality as being our ultimate driver. A new procedure perhaps becomes available, a new technology, maybe clinicians and patients lobby the politicians to introduce that. When you look at it from an evidence base and think about it in the context of what you're trying to achieve for the whole population and your commitment to quality, then these two things don't necessarily add up. And trying to hold your nerve and give a commitment to the chief executives and the patients and the public that actually you do want to provide a quality service, but that does mean that there are some things that aren't effective and aren't evidence-based, and that perhaps we don't do them then because they wouldn't contribute to our longer-term vision is a really hard thing to do. So on that note, I think I probably overrun my time a bit.
No, you did just fine.
But, thank you very much.
Thank you, Jill. So I have loads of questions about the drilling down to the how-to, how you get from vision to strategy to your initiatives, but we'll save that. And Jonathan, just make sure that you're speaking directly into the microphone.
Okay.
Thanks.
Okay, thank you. It's bright. My name is Jonathan Gray. I'm the director of Awatea, which is our Institute for Improvement, Education, Capacity Building in New Zealand. In part of New Zealand. We're based in a district health board in the north part of the island. The population, for those, as we've raised it, of New Zealand, and I did check, that was all I was looking at on my iPhone, is 4,432,726 as of 15 minutes ago. And my ambition is to be very careful here, because a child is born every 8 minutes in New Zealand, and there's a death every 19 minutes. So my ambition is to finish this talk before there are any deaths. Okay, so let's go. You ready? I've taken a slightly different approach again. Mine, I like coming to do talks, as you'll find out as we go, and I don't usually follow the rules, so I'm really sorry, Penny. And part of the fun is seeing if we can stress Penny, because she's such a really lovely person that she never gets upset, so let's watch her as we go. But what I wanted to do in this was do a bit of sense-making. I wanted to try and understand what is the context we're doing this work in, because how do you build a strategy if you don't know what the context is? And when I'm thinking of strategy, I have to look it up every time, but I like Marshall Ganz's definition that a strategy is how we use what we have, the resources we have, to get what we want. So what's the context? How are we developing a strategy to deal with that? So let's look at a few of the challenges that are out there. There's the usual ones, the ones that are right in our faces at the moment. You know, there's the money, NHS cuts, Barcelona doctors and ill patients protesting, and it's not just healthcare, public service cuts, big changes. What I wanted also to do, though, was give you a minute on looking at this not from a healthcare perspective, but looking at it from other industries as they look in. So if you look at the big companies, the Coca-Colas, the McDonald's and others, what are they doing and what are they seeing when they say what is the global challenge that we have to find a strategy for, of which quality is part? So if you look at that, what you see is they recognise that there is a huge expansion of need and healthcare in many other countries. And it's obviously looking at it from an American, a European perspective, but there's a massive expansion, and there's a lot of healthcare tourism starting. You look at whether it's the US or New Zealand, there are not enough doctors. I'm a medical geneticist, I've done public health, and I'm now lucky enough to be in the improvement world as well, but genetics, they're still predicting this huge impact on healthcare. Life expectancy is going up across the board, and that's going to bring its own challenges. The rising costs of healthcare, whether it's in New Zealand or in Europe or in the States. The impact of global pandemics and our ability to respond to those, and the huge numbers that are involved in anything like that. I picked one on air pollution, because for me that's, you know, how often do we talk about it? But look at the number, 2 million premature deaths per year worldwide just through air pollution. Evidence-based medicine. We know the challenges. It's wonderful that Beth McGlynn's just been recruited by Kaiser to lead on an evidence into practice piece of work, but we're still quoting Beth's work about 50% of evidence-based interventions being applied. We know it's a huge challenge. And the cost of extra years of healthy life. 100,000 now has moved up to 300,000, being the estimated net cost to add a quality of life adjusted year in the US. So the cost of us getting older and living longer. The ability to do some of the prevention work, whether it's the Gates Foundation or some of the other global health initiatives, but the huge challenge we have of saving lives worthwhile. And I touched on it because I think it's really important, and we're seeing it a lot, is the impact of medical tourism. The spending on preventable disease. So I ran through that because it intrigued me when I was looking at it, because now I'm going to take you back to where I usually give, which is the impression I have looking out from health and healthcare. But bearing in mind, those are the top 12 things that many of these big companies are looking at when they're thinking about what's their strategy and how will their approach to quality be involved. I'm very interested in thinking this through, because the strategy that we have to take forward has to address this problem that you and I have seen in every organisation we've ever worked on. There's always a new fad, we bring in a new idea. As we improve, the tension in the organisation increases, and usually, maybe it's me, but many of the organisations I've gone through, the performance starts to drop off again. And then a short time later, you start to get another fad and another go at it. So how do we take off from the top of that curve and keep moving forward? And I think it's partly about addressing some of these challenges, and that's where the quality agenda comes in. So sustainability, the excellence, as we've discussed just now, in a difficult financial environment, keeping great staff. So often, great staff leave, we've built it around individuals, and we struggle as organisations. And making system sense. Let's move around systems rather than organisations. So a great friend of ours, Samua Gray, talks about quality, safety, value, inequalities and prevention as the first 5 challenges that we've had a start on. But then, as I've drawn to your attention, we're talking about expectation, need, climate change, and money's often put first, I've put it last. So it's really, really messy. How do we make sense of it? Well, David Galler, a good friend of mine, and Muir came up with these ideas that we could talk about revolutions. So is it all hopeless? Well, no. Let's look at history again, because history teaches us that we're good at dealing with these terribly complex, wicked, difficult times. And the first time we did it, perhaps in historical recent memory, is the first revolution around public health. A huge impact, many lives saved, much harm avoided by a simple intervention, a public health intervention around clean water. A second revolution, what do we learn from that? Well, that was a revolution perhaps around technology. The ability to save lives and heal people and keep them well and extend people's lives around fantastic technology. I'd suggest there's been almost a third revolution around quality, but if you look at Lucian's work, and we all know this, actually we've not got there yet. We're staggering on. It's about 2.5, isn't it? It's still a problem. And if you look at all of those revolutions, we can learn and we can predict what some of the strategic responses might be. And I think this is where quality and our strategy starts to come together. Because if you take Manuel Castell's work about this, he would predict that in all those revolutions, the things that you come back to time and time again are people, relying on people. Oops, sorry. You've got control of that, Penny, haven't you? You made me on. Believe in people. So how do we invest in people and build capacity? It's about systems, not institutions. It's not hospitals. We've got to move away from that. It's about the supportive culture, the right technology. My 11-year-old has far more technology than I have, but what's the right ones we need to do the job really well? And then manage knowledge as if it was money, or even more provocatively, as if it was water. Clean, clear, fresh water that comes when you turn on the tap. Wouldn't it be great if knowledge was like that as well? So in trying to get to this better place, I'm lucky. I've moved to a fantastic place in South Auckland where the future has arrived, though. We've got huge issues around obesity and diabetes, massive challenges. We're disease-rich, but we're also rich in a fantastic culture and an energy of people who are determined to make a difference. Very, very fortunate to be there. And the proof comes that small countries like ours, 4 or 5 million, we can be world champions. So it's a real hopeful message, but there's something in Manuel Castell's about being an All Black that teaches us what our strategy should be. And although the All Blacks were rigorously trained, we all know, if you watch rugby and you watch any other professional sport, there's also need the odd crazy one, the misfit, the rebel, the troublemaker, the person who'll speak out. So while we're putting together these strategies, we've got to encourage these people too. The thought that's going through my head as we're trying to build these strategies is constantly asking where are the leaders in these strategies. And our recent learning, and Dave's done some great work on this, is to think about, let's keep asking those leaders these 5 leadership questions. Do you know how good you are? Do you know where you stand? Do you know where the variation is? What's your rate of improvement? Do you know where the money goes and what you get for it? Talking about value. So I'm deliberately keeping it fairly broad because when you look at our strategy in counties, our district health board of 500,000, and what I see developing across the country and in some other areas, we're moving away from the old message of high value, low value, of improving what we do to increase the value alone, to actually moving to choosing what we do to increase the value. So high value will be added value from doing the right things. And I heard that in each of the talks that you've just heard too. So the basics of our approach, and then I'm going to show you a very short 4-minute video to give you an idea of the flavor of how we're actually manifesting it, is about variation, reducing unwanted variation, sustainable systems, planning as a population. Once you put your arms around a budget, keep it fixed. Force the disinvestment, reinvestment, innovation within a group. If you know you've got 500 million for respiratory diseases in a population, well, give it to those extremely clever clinicians and managers who work on it. There is no more money, but what can you stop? What's the provocative variation that happens within that so that you can reinvest and innovate with what you've got? Shared decision-making and population medicine, of course. So our strategy is simple. Motivate, innovate, get results, and build capacity. New Zealand, a small country of 4 million people here in the South Pacific. Like every country in the world, we're facing some common health and healthcare challenges. In South Auckland, we're making some great progress, but there's so much more to do. We're good, but we have a very clear aim. Our communities, our patients, our families demand that we have the best healthcare system in the world by 2015.
In order for us to resolve the issues that we have around excess demand, we have to change how the system works.
The system has been designed primarily to take care of disease. And we know really that the future of healthcare is going to be to move down that continuum to health ease, to really starting to think about how do we promote health as well as take care of people when they're sick.
Awatea brings together the community to tackle these issues head-on.
I've no doubt this is going to be the light bulb in which we're going to drive some innovative thinking based on real evidence in transforming our healthcare system, not just in New Zealand, but also it's going to have an influence globally.
This is an innovation that's coming straight out of the heartland of New Zealand, out of one of the most diverse communities, and I totally support them. And I thought of a little song this morning that might actually just do my little bit for the cause and send my best wishes, my love to everybody down there. It's called Ray of Hope.
Together, we're bringing together great people, great knowledge, great innovation and great energy to drive forward the changes that are needed for 21st century healthcare.
Lay a blanket on the ground, together watch the world go round.
Working in silos will be a thing of the past as people come together around a common aim. Everybody has a role to play.
When I see the sun light up your face, it's coming like a ray of hope.
Our real success will be measured by the innovations we bring and our ability to implement them to shape the future.
Let's do it!
With the help of the Institute for Healthcare Improvement, the 20,000 Days campaign will reduce the demands on our hospital and give back to our community 20,000 well and healthy days by July 2013.
Every country in the world is facing 5 big problems: variation in quality and outcome, waste of resources, inequity, harm to patients, and failure to prevent preventable disease. But 4 new problems are coming.
I can see the potential that Awatea has to put New Zealand on the map as a leader of world-class healthcare.
Simply doing a more efficient version of the same is not enough. There's a lot to do, and building capacity, building great people, will be a key priority. The challenges we face here in New Zealand are universal. And through Awatea, we're meeting those challenges head on.
My name is Anthony Borich, All Black and member of the Blues. Greetings to all of you on behalf of all my Blues teammates, and a very special hello to all the Kiwis lucky enough to be there in Paris. I hope that many of you will visit us at Eden Park in Auckland later this year when you attend the Asia Pacific Forum hosted by the IHI and Awatea.
Come and join us at the Asia Pacific Forum in September. Come and learn, come and share. Thanks very much.
Thanks, Jonathan. I can always count on you. Okay, questions. I have some, but before I start with mine from the audience. To any of the speakers.
Thank you very much. My name is Dr. Nadra from Afghanistan. First of all, I would like to thank for a very comprehensive presentation. We learn a lot because we are in this first steps that want to improve the quality in our health service in Afghanistan. I hear the all presenter, but I want to start from Professor Martin from New Zealand. You mentioned that for sure that we should look into the sustainability And based on that, that every day the expectation is increased and the need is increased, and based on the problem that climate issues and that. And also we have to look into the economic crisis. This is the global problem around the countries. But in presentations we hear from colleagues from Scotland, you mentioned that there is no need for additional costs for providing quality service. I think when we set up the system, for sure, maybe at that time, no need more cost. But when we are in the first step to set the system, I think it's need the cost. And providing service with high quality, need capacity building, need qualified human resource, need better infrastructure, better equipment, quality medicine. For sure that it needs high cost. So just my question is that based on this problem globally that we are discussing about the expectation of the people and looking to the sustainability of the service around the countries, how we should mention that it's no need the cost, because the cost of service, it is increasing yearly because the expectation is become increased each year. And my other question is that colleagues from Singapore, you mentioned that the expenditure in your country is 3.9 from the total cost, but from Denmark it is 11%. So it means, do your people have own contribution, like insurance or like cost recovery on like this? But because in Denmark, you mentioned that the health service is totally free for all the people. How you manage? Because from our country, the 4% of our national budget coming to health, that it's very, very less. For sure that we are a low-income country and poor country and developing country. But it is necessary that we know how much is the cost per capita in all, in Scotland and in Singapore. And in Singapore, the health service is free for all the people. And all your speakers believe on that quality service, no need additional costs, or it is need for improving the quality, more cost. Thank you very much.
Okay, Jill. Or Jonathan, so we're dealing with the question of the financial investment in quality.
So I'll have a go, first of all, at answering the sort of the initial question that you said and you came back to at the end. And I think it's a really important point. I think that the message that we are giving is that it is by pursuing higher quality, reducing variation, reducing inappropriate variation, reducing waste, etc., we will, in the longer term, as you rightly say, achieve cost reductions and through that sustainability of our health services. And we are doing that in a way that is improving quality. So that message that improving quality reduces cost is hugely important. But I think you're absolutely right. We do need to recognise, though, that in the very short term there is some investment that we need to make in order to secure these longer term cost reductions. So I think my initial response to you is being honest about the fact that you do need to make some initial investment is really important. Otherwise, we won't get some of these initiatives started, which will result in much more significant reductions in the long term. So I think that was really an acknowledgement that the point you make is right and honesty about it is right, but the savings are so much bigger.
Just to add to that, in each place I've worked, there has needed to be an upfront investment to allow the quality improvement to be kick-started. And I think your comments about capacity building are really important, because occasionally we've put some money up, but not enough to build capacity going forward. So things have started and then they've fallen away again. So I think actually you need to think really hard and be really clear about the sufficient amount of funding to get there. The best speaker I've seen on that at this conference so far has been Lisa Schilling from Kaiser Permanente, who has data that show that her original challenge from the organisation was to show her return on investment, and she showed a return on investment of 2 to 1, 2.3 to 1 for her money that she was given. So she had a large amount of upfront money, and she showed a return of 2 to 1, but over 3 years.
Well, looking at a healthcare system like ours, we know that there's an extremely amount of waste in it. We have used the waste identification tool that has been launched by the IHI and the Health Foundation, looking at each bed at a department, and about 1/3 of the bed you can check that there's a waste, whether it's a healthcare acquired infection or whether the bed is empty at the time or so on and so forth. You asked how much do we spend on healthcare per capita, and I think in dollars in Denmark it is $3,000. I have one who can count right here, a Dane that can count. Det er 17.000 kroner, so it's about $3,000 per capita. Not everything is entirely free. Dentist care you have to pay a proportion of. You have to pay a proportion of the medications that you're taking. But except from that, healthcare is free. But
we use $11 per capita.
Yes,
When
and
we compare $11 per
yes.
capita to 3,000, how we should compare our quality service to
Yes, but I think that a good explanation for that might be the drawing that Maureen showed in her keynote yesterday, where she showed all the different kind of things that meant that had some influence on the health of the people, and healthcare meant very little to that. I don't know if you remember that, but I think that could be the explanation.
Yeah, in response to your question, firstly, the 4% GDP on healthcare is the total expenditure, which includes the government and the private, so it's everyone's expenditure included in it. And in Singapore, we do not provide free healthcare except in certain special cases, which I will elaborate later. We believe in the principle of co-payment, that patients have to pay because it helps to incentivize them to firstly stay healthy, because if you fall sick, you have to pay. 2, plan for your future, so you start saving for it. And 3rd is to choose your services wisely, because when they have to pay, their expectations actually go up, and it makes the providers also stay on their feet, that patients have a choice. They can always choose elsewhere to go. But in response to your question about do you need to spend more? I agree that spending on key areas, strategic areas are essential. So, like in Singapore, our government healthcare expenditure will double over the next 5 years. So it's a significant increase. So it's not that because we go on this quality movement, therefore we are not going to invest more. Instead, we are going to invest. But the question that has been posed to us is, for this extra money, what value are you giving? And in Singapore, we have, when we first started at our independence in 1965, our GDP growth and our earnings was relatively low. At that moment, the decision was made to invest in public health. So we had hospitals which were inherited from the British. We kept the hospitals as they were in the initial few years of our independence. We started by investing in public health, and those were the areas that we provided free. Immunization, clean water, all those were provided free because they are public good. And we found that this has actually improved the lot of the population very much. It was only after all these measures had been put in place did we then start our program of building hospitals, of upgrading our hospitals. And that started only in the 1980s, around 15 years after our public health measures. And concurrently with the building of hospitals, we also went ahead with our capability building, which is the manpower part, training the doctors, training the nurses in the relevant areas. But when we started, we were also careful that we do not train them at the subspecialist level, because they should be as generalist as possible, especially at the early stages. It's only now that we are starting to get more and more subspecialization. But even then, we recognize that we need to retain a core of people who can manage the general conditions. So I think that's how we have looked upon this, as it is not a question of how much, but it's a question of what value are we getting, what is the strategic priority at a time, and what is the context and the issues that are faced by the population. So we started with public health, hospital capability building, and also the specialization.
You're raising a really good question. Sheila, can I put you on the spot? So I know that each of these countries and regions are making a financial investment in quality, but you've done a tremendous amount of work in low-resource countries. Can you speak to that? What's their approach?
I'm Sheila Leatherman. I'm a professor of global health policy in the U.S. and work with Afghanistan and with a number of countries around the world. So I would actually say that for OECD countries, it probably is a matter of how you're spending the money and getting the greatest value for it. I don't think that that's true across the world. I think that there are very real issues, certainly in low-income countries, even the low middle-income countries, that they simply don't have a sufficient level of funding and health expenditure in the country. So I would say these are two different issues and really different ways of addressing the problem of quality. But to get to the level that is needed for even basic quality in a number of countries, they need additional investment in human resources and infrastructure and reliable drug supplies, et cetera.
Thank you.
Thanks. Ross Bailey from Brisbane, Australia. Really just a comment, and it follows on from Sheila's comment and from the question. I came to this session because it was titled, we say, Quality as a Global Imperative, but really we've heard from 4 high-income countries. My understanding of global is that it is about understanding global issues, and we've heard quite a few comments about equity, inequity, and the importance of quality in addressing inequity within countries. I was expecting to hear more about inequity at a global level. My understanding of global health is that it is about a sort of population perspective of health in the globe. And the majority of people live in low and middle income countries who are facing the sort of challenges that were raised for Afghanistan. And the question for me is, well, what I was interested in hearing more about was how do we pursue a quality agenda at a global level, both dealing with cross-country inequities, but also quality agenda that is relevant to low and middle income countries. And I appreciate Sheila's comment, but I would just make a plea to others, and this is sort of reflecting on the sort of presentations, plenary presentations, workshops, seminars, posters that we see here, very, very heavily dominated by high-income countries, North America, Europe. To me, coming to this session that's titled Global Health, I guess I expected something different. And if other people here have the same experience, I just make a plea to you also to approach the conference organisers so that we can perhaps see more a better global perspective in future conferences. Thanks.
Thank you, and I appreciate your comments, and we'll definitely consider that next year in our planning. Thanks. Other questions for these presenters?
I guess this is again taking more from an OECD type country perspective, but from a lot of the presentations, particularly the keynote this morning and others, it seems to be quite clear that some of the solutions are really going to be in integrating care across the population, across acute care and across chronic care. But the way health is organised, and perhaps a lot of the people who, at least from OECD countries, who are here working in the acute sector. So who is actually going to do this integration of healthcare to get these better outcomes, and how is it going to be paid for? Because in a lot of countries, the funding for acute care and chronic care is quite different, and there's no real mechanism for integrating that, either the management or the actual implementation of it.
John?
I could speak to that a little, being very conscious that my chief executive's just walked in the back door, so I'll be very careful about what I say. But your question was around where's the integrator, I think, and I think that's always fascinated me around when we're looking at the triple aim and when we're talking about that. And in one DHB, District Health Board, 500,000 people, we're making some steps to try and approach that. So we're working on a locality strategy where our entire community is split into 4 different localities, and the anticipated rise in money that is coming on a capitation basis into our system will no longer be predominantly moved into the hospital sector. It will move, the increase in money initially will move into those localities, but very firmly linked to the ability of those localities to help us attain our aims of reducing hospital-based activity. So there's an attempt for a district health board to be an integrator in its community. It's a first step. It's a long, long way to go. And we're very keen that there's a lot of cross-sector work that needs to happen. But for a much more wise discussion of the challenges, I'd very much nominate my chief exec at the back there for you to pin in with the difficult questions that go with that, because it's an incredibly big move and has many tensions in it, as you can imagine.
Okay, Jill, and then we're going to have, it's Janice from Denmark. And okay, we don't have a lot of time,
right,
but let's keep going on this theme of the integration and the financial incentive.
I mean, like New Zealand, we are in the early stages of working out what integration means. I think there have been a number of presentations over the past few days which have recognised that there's different types of integration that we need to pursue. We need integration, better integration between primary and acute services, but there's a big policy drive that we have at the moment which needs to build on that, is the integration between community services and health services, and as a result of that we are developing the flexibility to have different approaches within different geographies in Scotland. So there are some sort of fundamental sort of key components that we need to have in place, and we're pursuing these as we speak, setting out what the sort of shared ambitions are in the context of the presentation I gave about our cross-Scotland commitment to quality and supporting people to be at home. And in the context of that, then, what performance management and accountability arrangements do we need to have in place, which will then be underpinned by financial discussions. So it's been a real tension so far in Scotland. How do we integrate these different workforces and different services which at the moment operate to a certain extent within silos and create real problems and transitions and continuity? The integration will save a lot of resource and also improve quality, but we do need to go through some of these mechanistic processes first of all, and we're building a number of models that we think will be able to address that.
Thanks, Jill. Jess.
Thank you. I'm Jared. I'm from Denmark. We're having the same kinds of discussions in Denmark, and we haven't found the solutions yet. We're also speaking about who's to be the integrator, and as Beth showed you, we have 3 political levels involved in healthcare. So, of course, we are discussing across these levels who will be best suited to take on an integrator role. And also, we have structures in our system that kind of forces the regions and the municipalities to work together with one another on making clinical pathways and how to solve rehabilitation services and things like that. But we're kind of having some evolutionary processes going around and making projects where you kind of try to pool some resources and try to work together, and we're speaking to the municipalities now on how to better to integrate the social care elements, because that's difficult. And in Denmark, it's under another ministry. It has its own laws and its own kind of way to work in the system. So that it's not easy, but I think we're working with it, and I think we're working towards a situation where we will also kind of, in the negotiations with the government, maybe try to say some of the money going to the hospitals, to the healthcare, can we use this together with the municipalities in better ways than we do today, where we have each our budgets. So we haven't solved it, we're working with it, and we see to Torbay in the NHS and see they've found some models there, and some different places in Holland also, I think they've worked with it. So it's kind of a movement starting in a lot of countries, but I don't think anybody's found the solutions to make it at scale yet.
Yeah, I think this is also a challenge that we face in Singapore, and one of the key challenges we have is that traditionally we have been very public sector centered, in a sense. When we were looking at integration, it was only integrating the entities that we owned. But we recognize that if we move to population-based healthcare, we need to integrate with entities that we neither own, neither do we fund in our system. So that is a big challenge for us. And I think this is a challenge which is relevant not only for high-income or high-resource countries. I think it is, even for low-resource countries, it is an opportunity for us to start out right. And I think the integration has to happen at multiple levels. At the ministry level, we see our role as setting the clear outcomes, the desired direction that everyone wants to move, so that we are all pointed in the same direction. Secondly, it's about setting the necessary key elements in place, like I described our integrated care path. So the key care elements must be the same regardless of where you go within the region. So once this is done, then we are setting up what we call our regional health systems. And under each of these regional health systems, it includes the people, which is the charity sector, the private as well as the public sector working together, and the funding will go to the regional health service headquarters, which would then flow the money down. But while we can flow the money down from the funder's perspective, because in a co-payment system, we also need to ensure that the financial gradient for the patient makes sense so that they can move in the integrated system. So we need to ensure that it is cheaper for them to be treated in a community hospital versus a tertiary hospital, cheaper to be managed at home compared to be managed in a hospital. So these are issues that we are trying. So for countries that are setting out, you have a chance to set the gradient right in the first place. Because for some of us, because of historical policies that we have, sometimes it's very difficult to unwind. Because once you give a subsidy, it's very hard to take it back. So these are issues that we are trying to grapple with. And I think one of the biggest challenges in creating integration is the mindset for integration. Because the hospital in an integrated framework needs to then think of itself as not the big brother in the system that eats up everyone else, but as a resource as well as to assist the rest of the community. Because I think in any sector, the hospital is always the one with the biggest budget, with the most talented manpower, the most number of staff, and most number of equipment. So instead of it viewing itself as it should be then contributing and assisting. So these are issues that we are grappling with, and electronic and information flow is also critical. So creating a network as well as electronic health records.
Other questions? Are you using financial incentives at all to help with the integration?
Yes, I think money talks. So we need to, so for example, in order to get our GPs into the system, we have now started offering them portable subsidies, that patients can now get subsidies when they go there. But in return, for them to access the subsidies, they must agree to submit clinical data to us. So compliance with protocols, and so it is in a sense, they get more patients, so their revenue would improve. But at the same time, the quality, we hope, also would improve. So it is hopefully a win-win. So we are trying to work out all these different types of a business case. Because the challenge we find is that as civil servants, we are not very good in doing business. And therefore, we found that the business part we leave to them. The quality part is something that we can talk on.
Mirwais Amiri from Afghanistan. Apart from the challenges that you mentioned in regards to integration of the strategy, what other challenges you see in establishing and maintaining connection between strategic level and operational level? And if you can give a background, like when you started with, because I'm coming from a resource-limited country, so that will be helpful for us too. Thank you.
Actually, I had the same question. So if you can kind of talk about the how-tos, how do you get there from the vision to the strategy to the initiatives? How do you operationalize that?
Thanks.
We're all looking at each other here.
It's challenging.
I'll be brave and have a first attempt. What we did in Scotland was, first of all, as you say, get the ownership and the sign up for a high level aim and vision about where it was we all wanted to get to, and we were very clear and continue to repeat that vision came from the things that people told us, the public told us that they wanted. So I think.
When you say we, can you yeah. Who's we?
Well, when I say we, I guess I mean that I talked about the Scottish Government working with the health service and on a sort of practical basis, that's with the sort of senior people in the health service in Scotland, so the chief executives and the senior executive people within the health service brought together all the information and knowledge that they had from the conversations that they were having with their public, with their staff, to the table, and we sat together and agreed collectively what that statement of vision was, and then put in place a driver diagram for which IHI will be sort of able to claim partial responsibility for helping us think in that way, and sort of started to map out what are the priority areas then that we need to take action if we're going to achieve that vision, and then started drilling that down into the much more local improvement programmes that we were going to prioritise in order to drive progress in these priority areas. So there are a range of different ways that is then being fed down into sort of operational activity on what you might call the front line. The people at the front line are becoming involved in the specific improvement programmes then that we're putting in place, and every time that they are involved in that, they are told exactly how that is going to contribute to the higher level aim. So everybody that is involved in these improvement programmes is having reinforced time and time again that's sort of single high-level ambition that we've got. We do have a problem, though, because we actually have a lot of understanding and buy-in at the high level, at the chief executives and the senior executives in the Scottish Government. We have a lot of detailed knowledge and understanding and commitment from those people at the front line who are involved in the specific improvement programmes that we're funding and driving and putting in place. But in the middle, we do have a problem in that the middle managers aren't involved in the delivery. They don't necessarily have the opportunity to think about how they personally can be contributing on a day-to-day basis to improving quality. And they're being held responsible for achieving some financial and waiting time targets. And that's one of, when we asked about challenges, that's one of our big challenges at the moment. How do we help the people in the middle of the organisation think about their role in contributing to quality and also be part of the movement and the language that we've got about quality as our priority?
I think from my perspective is that firstly we need to start with the need, not what we want to do, but what is the population's need. And we do not require actually a very intensive data gathering method, because in some cases the need is actually staring us in the face. But I think it is important because, as Jonathan says, there are a lot of fashions and fads that come by us every day, and there are a lot of new ideas that come. But are these applicable for our population? So what is the need of our population? And then based on this need, it will resonate with the people that we are working with. The next thing I feel is that to get this done is also the softer side, which is the element of trust within the system. Although I've mentioned that the money talks, but money as a lever can only work to a certain extent. Because in a commissioning relationship between a purchaser and a provider, it works in situations where the outcomes are very clearly defined. For example, cataract surgery. I know, and the patient knows, if after the surgery I can see, I can't see. But in cases where it is more complex and the outcomes are more nebulous, caring for the elderly, it is quality of life issues and all those. If we just go on a commissioning model, purchasing a particular services, I think it would not fully capture the qualitative as well as the quantitative aspects of what we desire and whether the need is actually met of the population. So this is where I think trust and conversations and working out an iterative model is essential. So it's rather than we have spent a lot of time keep working out a grand plan, and after this grand plan is ready and we just roll it out and say you implement. It is actually having something to seed, and from there working with the community to see, and the community includes the providers, the patients, to see what then is the best solution that will meet their needs. So I feel that strategy can be done, the broad strokes can be done centrally, but definitely the implementation as well as the rollout has to be done locally.
Beth? From our perspective, which is the Danish Society for Patient Safety, the way we work with it is that we are trying to get the decision makers interested in what can other countries or other places accomplish. For instance, over the last 4 years, we have had a Viking invasion of Scotland, and I think Scotland is one of the world leaders in the quality and safety work in our part of the world at least. And by exposing decision makers to what is going on in Scotland makes it very uncomfortable for them to come home and see how we are doing. So that's part of it, is being a little uncomfortable about what are we accomplishing. Look what they can. They probably even have fewer resources than we have. And then we have been able to establish some demonstration projects that are successful. And we don't, for instance, now we're working with 5 hospitals. We don't really care about 5 hospitals. We care about the whole country. But the way to get to a national agenda is to have exemplar sites that can make that can make it possible for you to achieve a higher aim. So that's how we are trying to go from strategy to reality.
Thank you. Jonathan, do you have any remarks? And then we'll wrap up.
Very quickly, my role in life is to give my chief exec the last word usually, so I'm going to ask Geraint just to say, because he was head of strategy and he led our quality improvement strategy.
He just wants to make sure I get some exercise, Geraint.
Thank you, Jonathan. I'll remember that when it gets to salary review time. For me, I think there's three major things when in terms of operationalising a strategy like this. I think the first one, it's banded on relationships. You need to make sure that you've got really good, strong relationships with the people you're working with. I think that applies particularly to the big brother effect. I think you need to build that element of trust. I also think you need to build the narrative. What you're doing here is major organisational change. Therefore, you need to really strongly tell the story about why we need to do this. And those two things take time. But I think it's time very well invested. Before you even begin to do anything, is develop that very solid relationship. The second bit about operationalising it for me is the realisation that in most health systems, secondary care is a big organisation with big money. It is also arthritic and lumbering as an organisation. General practice, primary care tends to be, and NGOs are a lot more nimble, a lot more entrepreneurial. You've got two very, very different business models operating. And I think what we've got to realise is the mutuality that goes with that. Primary care NGOs find it very difficult to carry risk. They're small organisations. A health board or a hospital board can carry a great deal of risk because they're big organisations. So, but what we can't bring is the entrepreneurship. I think that the trick is to find a way of melding the benefits of both of those systems together for mutual advantage. The first thing I would say, more than anything, is go for scale. One thing that really worries me is that we're talking about changing how a system works. So the thing that I get very concerned about is where people run off and do little change. I think you get one GP, half a dermatologist, a faith healer, a crystal shop, and a lab station, and people go, oh, that's going to change the system. Well, it won't. I'm not saying there are bad things, but you have to think broader and bolder. So somewhere between those two business models, you've actually got to create a scale and mass in order to develop new services. And the third thing is, I think, go out finding out what's best practice, but also finding a way in which you can bring to people examples of what does work. And I think, particularly when you're talking to clinicians, if you give an example of what has worked with evidence, they'll tend to buy into it a lot more than some airy-fairy management concept. So those two, for me, would be the three areas I'd be concentrating on.
Thank you. Okay, I don't want to hold anybody any longer because I know that it's lunchtime. Before I thank the presenters, I again want to apologize for any poor advertising about the program, and I can assure you that we will be much more sensitive to the design of these in the future. So I really take your feedback seriously. To our presenters, I thank you so much for sharing your progress, your learning, your struggles with all of us. You've been absolutely terrific, and I thank you deeply.
Thank you.
That was good too. Good to hear you.